of direct. And we are going to be recording tonight's. We do have a YouTube channel. Remember, we're trying to get to 100,000 subscribers and we're at like 48. So please go join the YouTube channel. We start making money at 100,000 subscribers. Okay, well, without further ado, Dr. Ewing, please take it away. I'm not sure where you're at though.
I believe Dr. Ewing was having technical difficulties and was signing back on and has not rejoined us yet.
Oh no. Okay, well, no problem because I'll just jump in then. Are you sure she's not back on? She was just here. Okay, well, I'll just start by saying that we have translation tonight. Cynthia, do you want to announce that? How to access translation.
Para los que están interesados, hay traducción al español disponible. Hay un globito hacia abajo y pueden hacerle clic ahí y ahí se lo oirán la presentación en español. Gracias.
And for people who are just joining, if you could also change your room name. Oh, there's Dr. Ewing. Okay. She just joined, Casey. Everybody's Casey O'Brien tonight, but if you'd like to be put in the raffle, please change your name. Sorry.
How do you know which one is your name?
Did you see her, Casey?
She's in, I hear her.
Dr. Ewing, where are you? There's so many people tonight. Wow, 105.
You, but hold on, just, oh, here we go. Let me, it took a while. Can you see me now? I think we're okay. Can you see me and hear me?
Yes, thank you. You look great.
Okay, that was a challenge. And it wasn't me, honest.
It was not you, believe me.
Anyway, I'm glad we're here.
Thank you. I introduced you and then we announced that Spanish translation is available.
Oh, okay.
Yes.
So
You can just take it away by starting to introduce our speakers.
Oh, fantastic. Well, first of all, I want to tell everybody how happy I am to be here to moderate this webinar that is bound to provide some excellent and useful information. And without further ado, since we're running slightly late, I will introduce Dr. Doris Kwon, who will be discussing extended half-life products. Have you already mentioned that the questions will follow the speakers, and then the questions can be also formulated in Spanish?
No, I haven't announced any of that, just the translation part.
Oh, okay. So let me just say, because I had my little speech prepared for that. So antes de comenzar, me gustaría anunciar que la traducción al español está disponible para este seminario web. Haga clic en el botón de Zoom etiquetado como interpretación para escuchar en español. En segundo lugar, haga cualquier pregunta que puede tener en el chat y lo puede decir en español y después vamos a proveer con una respuesta con eso. Gracias. Okay, so Dr. Kwon, I see you're there. Would you like to start?
Hi. Sure.
Hi,
So I just wanted to clear up. So are we going to have questions after each section, or are we going to have questions just at the end of all the presentations?
My understanding was that we will be doing this at the end for everybody together. Is that correct? Casey, you've been organizing this, and that was my take from the correspondence.
Yep, at the very end of all three presentations.
Right.
Okay. So I did prepare a few slides. So I'm not sure how to exactly, do you just give me control and share screen?
Yep, Dr. Kwon, you can just hit share screen and just pull your slides right up.
I think that's it. And
Yep, there you go.
And is that showing up?
Yes, it is.
Okay, so let me sort of fix my screen here a little bit. So I was tasked, so there's 3 different topics today, and I was tasked to talk about extended half-life factors. I believe Dr. Young is going to be talking about some non-factor therapies, and then Dr. Soni is going to be talking a little bit about gene therapy. If I got this wrong, please just jump in and let me know. Is that correct?
That's correct.
Okay, so just really quickly, again, most of you know who I am. I'm Doris Kwan, and I'm from Orthopedic Hemophilia Treatment Center. And we more or less specialize in taking care of adults with bleeding disorders, hemophilia, and von Willebrand's, et cetera. These are my disclosures. I just wanted to let other people know that I am on other pharmaceutical speakers bureau, so those are listed here. And this is just kind of a brief outline of what I'm going to be talking about. I don't know that anyone here really needs an introduction because you all are familiar with hemophilia. And what I'm going to talk about first is some of the current therapies, a very quick review on standard half-life factors and extended half-life factors, and then what's emerging investigational products for extended half-life factors. And I don't know what just happened, but so as you all know, hemophilia is a bleeding disorder, and it's a result of clotting factor 8 or 9 deficiency. Hemophilia A is factor 8 deficiency, also known as classic hemophilia. Factor 9 deficiency is known as hemophilia B, or Christmas disease, named after the first patient and not the holiday. The frequency, there's approximately 20,000 individuals with hemophilia in the United States, and this is based on the CDC data. Hemophilia A, the frequency is about 1 in 5,000 male births. Hemophilia B, approximately 1 in 25 to 30,000 male births. So hemophilia A is much more common. There's actually, many of the cases, 30% of the cases have no previous family history. I know most people think that this is genetic and it's congenital, but 30% of the cases has no family history at all. And all races and economic groups are equally affected. And hemophilia severity is really defined by what we measure as factor levels, with mild hemophilia defined as having 5 to 30% factor activity compared to normal, moderate hemophilia 1 to 5%, and severe hemophilia is less than 1%. So we can draw blood and measure factor levels, and if you fall into the different categories, for example, your factor level is 3%, then you fall into the category of moderate hemophilia. If you're less than 1%, then you're severe hemophilia. And the signs or symptoms are essentially listed here. Where severe hemophilia, you can have spontaneous bleeding, and 70 to 80% of the bleeds are into the joints, more commonly known as hemarthrosis. Mild hemophilia, you don't usually have spontaneous bleeds unless you develop a target joint, but usually you have prolonged bleeding after surgery or trauma. And moderate hemophilia is sort of in between, where you can have infrequent spontaneous bleeds, but a lot of bleeding with even minor trauma or after surgery or dental extractions. And so hemophilia care, the goal of the care is to prevent or treat bleeding. And to prevent bleeds, the optimal management has been prophylaxis. This is recommended by National Hemophilia Foundation, the Medical and Scientific Advisory Board, as well as the World Federation of Hemophilia. And so prophylaxis could be different things nowadays. And I'll be talking about some of the factor products that were used for prophylaxis, but now there are different products that people may be using for prophylaxis. And people with hemophilia are really best managed in a comprehensive care setting where there's a multidisciplinary team of healthcare professionals to take care of these complicated patients. And I just wanted to review some of the hemophilia care. And this is a timeline of the hemophilia care and the treatment products over the 60 years here. And so I put this little red here. This is when Orthopedic Hospital was first established, where we are now. And you can see over the 60-year span, there's lots of different products that have been developed and come to market, and lots of treatment options currently. Where back in the 1960s, the only thing really available was plasma, and then the concentrates, plasma-derived concentrates, were developed in the mid to late 60s. We had them in the early 70s and even the early 80s. And unfortunately, we did have viral complications and people became infected with hepatitis and HIV during the early 80s. And then the mid 80s, we had the virally inactivated plasma concentrates. And then with the newer technologies and molecular techniques, recombinant factors were able to be made. And the first FDA approved product for factor VIII came out in 1992, as shown here. And then in 1997, the first recombinant factor IX product came out. And there were some development of some other factor concentrates, including the third generation factor product in 2003, but it really wasn't until 2014 where there was a breakthrough and the first extended half-life factor concentrate was approved by the FDA. And then shortly after that, in 2017, this was a great breakthrough, and Dr. Young will be talking about this, the non-factor treatments. And now we've had a lot of excitement going on and talks about gene therapy, and Dr. Soni will discuss that. And so I just wanted to quickly review the current hemophilia therapies, and you can see this is a really long list of therapies for factor VIII. These are the standard half-life therapies, and just to reiterate, the first product that was approved was in 1992 for factor VIII, and that currently is still on the market. It's made by the manufacturers are shown here, Takeda, and it's a full-length factor VIII, and you can see the half-life shown here. It's 15 hours. So again, just the name of the product, the manufacturer, the structure, half-life, and the approval time. And then this was followed by Cogenate, which is again a full-length factor VIII, and that initially was approved in 1993, and then it had a reformulation and became Cogenate FS. Again, this is by Bayer, and again, this was the second iteration was approved in 2000. And as I said, there was a third generation product for factor VIII that was approved in 2003, Advate. And you can see again, just to point out, the half-lives are shown here. The first B domain deleted product was Refacto, approved initially in 1999, and then reformulated. And this is now made by Pfizer in 2008. Novo 8 by Novo Nordisk is a B domain truncated factor VIII product that was approved in 2013. Nuvic, this was the first product that was approved that was made in a human cell line, and that was approved in 2015. And Cavaltri and Afstyla, made by Bayer and CSL Behring respectively, was approved in 2013. And Cavaltri is a full-length factor VIII, whereas Afstyla is unique. It's a single chain factor VIII B domain truncated with a heavy and light chain that's covalently linked together. And just reviewing quickly, there are 3 standard factor IX half-life products. Benefix, which was the first approved in 1997, and this is by Pfizer. Rixubis from Takeda in 2014. Ixinity by Apdivo in 2015. So again, these are the standard factor IX products. And so now I'm going to talk a little bit, changing the topic back to where we want it to be, which is the extended half-life products. And I just wanted to talk a little bit first about how the products, so we talked about the standard half-life products and that they're recombinant and they're essentially made in the laboratory. And then these products were then modified to make them longer lasting. And the goal of these longer lasting products is to ease the burden of infusion. So we know with the standard half-life products for hemophilia A, factor VIII, you have to do infusions every other day or 3 times a week, and that can be burdensome. With a product or a factor that's longer acting, you can have the same protection, but maybe infuse less often. And so that was one of the goals with these extended half-life products, is to ease the burden of the care. And so there are the 3 mechanisms of half-life extension are shown in this slide, and I'll be talking a little bit about the products in a minute. So the first one shown on the left-hand side of the slide is a fusion protein, FC fusion, and there's another type of fusion protein called the albumin fusion, and I'll be talking about that. This is a factor IX product. So the FC fusion is where so in the, it's genetically, we take the DNA of interest, and in this case, it would be either factor VIII or factor IX. You take the protein of interest, the DNA of that protein of interest, and you fuse it with the FC portion. And I know this might be a little intimidating, but so when we make the fusion protein, we take the FC portion of the human IgG and we fuse it to the factor. And the rationale is that the IgG has a long half-life, which is about 3 weeks. And through this FC fusion, you get binding to a receptor, and this recycles the product, making it longer lasting. And the other mechanism for factor VIII extension is called pegylation. And so the number of products are using pegylation to extend the half-life. And what the pegylation does is you make the protein, the factor, and then after the protein is purified, you add or modify it by this molecule called PEG. It's polyethylene glycol, and the structure is shown here. And what this does is that it creates what we call a cloud, and it protects the molecule. The PEG is attached to the factor, and then it protects it, and the molecule is basically too big to be cleared by the kidney or the liver. And the last way, and this is for factor IX specifically, is that the factor IX molecule is linked to albumin, and the albumin has a long half-life at approximately 3 weeks. And so that, similar to the FC fusion, it extends its half-life and stays in the body longer by doing this type of fusion. And so here are the molecules that are available for factor VIII extension. And the molecules are shown here. The names are here, the manufacturer, the mechanism of extension, the half-life, and when it was approved. And so Eloctate was the first molecule approved in 2014. It's made by Sanofi, and it takes the factor VIII and does the FC fusion. And this fusion protein delays the breakdown or degradation. And the half-life is approximately 19 hours. And if you recall from before, the standard half-life products for factor VIII range anywhere from 8 to 12 or 14 hours. Here it's 19 hours, so it's extended by doing the FC fusion. Adinavate, which is made by Takeda, was approved a year later in 2015, and it's a pegylated product. It's a small PEG molecule which is added to the purified adinavate, and so this base molecule is adinavate, and the adinavate is pegylated to make, the advate is pegylated to make the adinavate, and the pegylation improves its stability and reduces its clearance. And the same Jivi is made by Bayer, and it's a pegylated, but it's B domain deleted. It uses a bigger PEG molecule. And again, with pegylation, you get improved stability and a reduced clearance, and its half-life is 19 hours, and it was approved in 2018. Esperat is the newest one, the newest kid on the block for factor VIII, and it's made by Novo Nordisk. It's glycopegylated. the PEG molecule is in between that of the adenivate and the GIVI. And again, with pegylation, you get improved stability with reduced clearance, and its half-life is from 18 to 19 hours, and this was approved in 2019. And now going to the factor IX products, there are 3 of them on the market. And so this is extended half-life factor IX molecules. Again, the name, manufacturer, mechanism of extension, half-life, and the approval dates. Alprolix was the first to be approved for the factor IX extended half-life molecules. It's made by Sanofi, and it uses the FC fusion. And again, to remind you, the FC fusion delays degradation and recycles the molecule back into your bloodstream. Half-life is anywhere from 54 to 90 hours, depends again on the patient and the age of the patient. And again, it was approved in 2014. Adelvion is made by CSL Behring, and it uses a fusion, but as I showed you at a few slides ago, it uses an albumin fusion. So the factor IX molecule is fused to the albumin, and this fusion allows recycling and delays the degradation. And the half-life of this molecule is approximately 104 hours. It was approved in 2016. And last, the Rebinine, it is made by Novo Nordisk, and it is a glycopegylated factor IX molecule. And again, just to remind you, the pegylation, it improves the stability of the molecule, and that results in reduced clearance. And its half-life, it ranges anywhere from 103 to 115 hours. Again, it's approved in 2017. All of these molecules have been approved for treatment of bleeding. Alprolix and Idelvion have been approved for prophylaxis. Rebinine is only approved currently for on-demand treatment. And last thing I wanted to talk about, what's emerging or what's coming out in terms of extended half-life products. Well, there's been a new product that's investigational at this time. It's still in clinical trials, and it was dubbed BIV001. And I really have a difficult time saying this name, but I'll call it EFA for short, or refer to it as BIV009. You can see the name is listed here. And this is, I'll show you what the structure is in a minute, but the base molecule is the FC fusion protein. And so this is a factor VIII that's been fused to the FC, IgG portion of the FC. So the FC domain is shown here. And as I talked about, the FC domain recycles the product, and it results in decreased degradation and extends the half-life through this FC neonatal receptor recycling pathway. This molecule has been modified, and just to back up a little bit, factor VIII normally in your body binds to von Willebrand's factor, and many of the factor molecules, its half-life is limited by the half-life of your own von Willebrand factor, because factor VIII binds to von Willebrand factor. And because of that, we can't extend that half-life beyond 18 or 20 hours because the half-life of von Willebrand factor is that long. So what they did was they modified this FC factor VIII fusion protein, and this is the area shown here. Sorry, this is a cartoon of the factor VIII, and the normal factor VIII then binds to von Willebrand's factor. And so what they did was they took this molecule and modified it and bound something here, what they call the D3 domain of von Willebrand factor. And through this, it prevents binding to your own von Willebrand factor, and it sort of what we call decouples it, or it separates it from the ability from this infused molecule to bind to your own von Willebrand factor. And by doing this, it confers partial protection from breakdown or degradation to factor VIII that's normally afforded by the von Willebrand factor. And after they modified it with this D prime D3, they also added what we call extend. And these are natural amino acids, and these natural amino acids are shown in these halo blues. This provides extra protection and increases the half-life even more. And this is how it's activated. So this BIV001, this is the BIV001 shown here. Again, a cartoon of the molecule, the factor VIII molecule with the modification of the FC, the D prime D3, and the extends. And so all of these things extend the half-life of this molecule BIV001. And so when you infuse this molecule and it needs to be activated because you're having a bleed, what happens is your body generates what we call some thrombin, and it clips these molecules to activate it. It clips this off and the extend molecule off, and it clips off this D prime D3, and in the body then it gets activated to this recombinant FC. So this activated BIV equals activated factor VIII FC molecule shown here. And so saying all of this, it was shown in the clinical trial when they use this BIV001 and they test how long this BIV001 works in your body or lasts in your body. These graphs show the half-life. So basically they took, they infused the factor and they checked your factor levels over time. So here shows your factor level on the y-axis and time over on the x-axis. And you can see in the light blue, this is one dose, sorry, just back up. This is one dose of the factor at 25 units per kilo on this left side. And the right side of the slide shows a second higher dose. And so looking now at the lower dose first, they found that when they compared it to this is a standard factor VIII molecule, and you can see the half-life was 9.1 hours. And when you compared it to the BIV001 molecule, looking at it, you can see that the half-life, if you calculated the half-life, this was almost 4 times as long. It's 37 hours. And then when you look at the higher dose shown on the right side, looking at the standard factor half-life molecule it was compared to, the half-life was approximately 13 hours, but using the higher dose of the BIV001, it was 42 hours. So you can see that this molecule is a much longer half-life. And so that's now, what I want to point out was this was done initially in a very few patients. Here you can see the BIV001 was used in 6 patients, and the average half-life was 37.6 hours. And here, using a higher dose of the BIV001 in 8 patients, it was 42 hours. And now they're doing a much larger study looking at it in what we call a phase 3 trial. And there's about 150 patients in this trial, and they're waiting for the data to see what it looks like and what the half-life might be before the FDA will approve the product. And again, this is in phase 3 trials. So just to quickly summarize, we know hemophilia is a bleeding disorder that results from a deficiency of factor VIII or IX, and we know prophylaxis is the best treatment to avoid the complications from repeated bleeding. Factor replacement has been the mainstay of treatment, and the extended half-life products can ease the burden of care, but non-factor therapy and other emerging therapies such as gene therapy may even ease the burden of care more. And I think I will turn it over to Dr. Young to talk about some of the newer products that might be coming out or are out already. Sorry, I hope that wasn't too fast.
All right, so let me share my screen. I'll have a sort of brief overview of the non-factor therapies.
I was going to introduce you, Guy, but
Oh.
I don't.
Yeah, go right ahead.
Larry, everybody knows you. But anyway, it's my pleasure. First of all, thank you to Doris, who's done an excellent job in reviewing the current progress on what's going on with the extended half-life products. And now I'm happy to introduce, for those 0.0001% of the population who don't know Dr. Young. And anyway, he's the director of the hemostasis and thrombosis program at CHLA, and he will be speaking about non-factor therapies. It's all for you now, Guy.
All right. Yeah, thank you. Sorry to jump the gun over there.
No, that's okay. I have to do my job, you know.
No, of course, of course.
Okay.
So in any case, let me give you a brief overview of non-factor therapies, since we've got quite a bit to talk about. Here are my disclosures, which include companies like Genentech and Sanofi that make, actually Sanofi should be on there. Oh yeah, it's up there, Bioverativ, Sanofi, that make some of the non-factor products. So just a little bit about how these things work. So this is on the y-axis, imagine that's the level of factor in your blood. 0, obviously, if you have none, 50%, 100%. And when we give factor therapy, it's not meant to be exact, but basically you get a peak and then it drops off. And then you give your next dose. You get a peak and then it drops off, and so on and so on. And so one of the weaknesses of factor therapy is you get all these low levels in between doses. And one of the strengths, though, is that you can give a dose that's high enough to actually even correct things completely to normal. Non-factor therapy works differently in the sense that essentially all these products have a very long half-life. So they stay in your blood for a long time. And in fact, you get a flat level. This area that I mark there is like basically for emicizumab. It's like between 10 and 30% is where people think emicizumab provides a protection level. So in the mild hemophilia range. But notice the black line means that wherever your level is in there, your level is flat. There's no peaks really, there's no troughs. I mean, minimal, but for all intents and purposes, you don't have these big peaks and troughs. Your level is steady all the time. Some of the other non-factor therapies that are in development, we are hoping, and we don't know that this will happen, but we're hoping that we can make a non-factor therapy that can actually give you a flat level that is even in the normal or non-hemophilia range, between like 50 and 100%, so that you have basically zero risk for bleeding. Again, there are non-factor therapies that are in trials. I'll talk about one. Actually, I'll talk about a couple that maybe can do even better than what emicizumab does, which is convert you to mild hemophilia. And then Dr. Soni will talk about gene therapy. I won't mention much about that other than say that gene therapy is meant to give you a level somewhere between mild to maybe even normal, and it should give you a steady level, but I'm sure he'll discuss that with some of the factor VIII gene therapies, we see levels that are decreasing. Anyway, that's all I'm going to say about gene therapy, and now we'll just get into the non-factor therapies. So this is, I know it's very complicated. This is the coagulation cascade, but just a way for me to show you where these things work. So in green is what I call substitution therapy. So medications that are substituting for something that is missing. And in red will be the rebalancing agents. And I'll explain what that means, rebalancing, later. So we're going to talk about two substitution therapies, mostly emicizumab, but another one that is in clinical trials called Mimate. I know it looks like Mimate, but the company prefers to call it Mimate. We'll talk about fitusiran. The dashed lines means inhibitor. So fitusiran actually inhibits or blocks antithrombin. Antithrombin blocks factor 10A and thrombin. So it's essentially blocking, inhibiting an inhibitor, having like that double negative effect, which actually then turns into a positive. And then we'll talk about some other drugs that are inhibiting the tissue factor pathway inhibitor, but only briefly. And in the future, there are products that are inhibiting other inhibitors. All the inhibitors are in bold, like protein C and protein S. So there's a lot going on. That's the bottom line, with products that are either substituting for something that's missing, like factor VIIIA, emicizumab and Mimate, or inhibiting one of the coagulation inhibitors, and thereby improving the formation of thrombin to make blood clots, which is all the ones in red. I will talk about emicizumab, briefly about Mimate, a fair bit about fitusiran, and a little bit about concizumab and marstacimab. Now, what's the point of non-factor therapy? So these are medications that are aimed at improving hemostasis, so improving your ability to clot your blood, but without replacing the missing factor. As we know, for decades, and Doris just presented the information about factor replacement, which is replacing exactly what is missing. That's different than substituting for the function of something that is missing. So non-factor therapies are medications that improve your blood clotting, hemostasis, without replacing what is missing. And they're designed in a way to make the treatment easier, so to reduce the treatment burden. So all of these that I just showed you, in fact, all of these here, all of them are given subcutaneously. So they're given as an injection under the skin and mostly at relatively infrequent intervals, every week, every 2 weeks, every month. There is one that's in clinical trials that's every day, but most of them are going to be, they're all subcutaneous and generally less frequent than factor therapy has to be given. So briefly, emicizumab. So what is emicizumab? Well, activated factor VIII, so the activated form of what is missing in hemophilia A, its job is to bring factor IXA in the red and factor X together to make almost like a happily married couple. And then that complex of factor IX and factor X, with the assistance of factor VIII, goes on to help you make a blood clot. Emicizumab looks like sort of factor VIIIa. It's a bispecific antibody, which means it's an antibody, but one that has the ability to bind two things. That's why it's called bispecific, for two. And it binds factor IXA and factor X, kind of like the way factor VIIIa does above, and then essentially brings them together in the way that factor VIIIa does and allows them to then function. So emicizumab essentially substitutes for the function of factor VIIIa and does what it's supposed to do, but even without having any factor VIII in the blood. So you don't need to replace factor VIII. There were a series of what are called phase 3 or pivotal clinical trials, Haven 1 through 4. These have been talked about a lot. I know I've talked about them at these meetings before, so I'm not going to get into too much details. Suffice it to say that these included patients with inhibitors and without, because since you're not giving factor VIII, this medicine will work whether you have an inhibitor or don't have an inhibitor. Doesn't matter, because the inhibitors to factor VIII are against the factor. They're not against anything else. Emicizumab is not factor. So it works just the same and is dosed the same in patients with inhibitors and without inhibitors. So it was studied, as you can see in the population, patients older than 12 with inhibitors, younger than 12 with inhibitors, older than 12 without inhibitors. There's also some further studies later on of kids without inhibitors and also with every 4-week dosing. And essentially, I'll show you the summary of the results on this slide. What this, it's called a donut diagram, you can imagine it looks like a donut, is that this is the percentage of patients that had no bleeding during the clinical trials. I should say no bleeding that needed treatment, what we call treated bleeds. So Haven 1 and 2, these were studies in patients with inhibitors. And you can see that 63% of the older kids and adults and 86% of the younger kids didn't have any bleeds that needed treatment during the study, which is pretty fantastic. In Haven 3, without inhibitors, it was around 60%. And in Haven 4 is around 60%. But then what was done was these patients were followed for many years, for like 3 to 4 years. This part of the trial was in the early phase after 6 months of treatment. But if you keep checking the patients, the longer they stay on emicizumab, and that's what this study is called, long-term outcomes from the Haven 1 to 4 studies, you get this picture. This is now in the y-axis is the annualized bleeding rate. So the number of bleeds per year. And you can see in all the studies, you started out with an average of 2 bleeds per year. But by the time the patients ended the study, this is the weeks of each study on the x-axis. So the first 24 weeks or 6 months, the next 24 weeks, the next. By the time patients were out more than 2 years into the study, the bleeds had gone almost down basically to 0. And if we look at the individual trials, Haven 1 was the adolescents, adults with inhibitors. Haven 2, the kids with inhibitors. Haven 3, the older, the adolescents and adults without inhibitors. You can see that the longer you stay on the medication, generally speaking, the levels of the amount of bleeding goes down. Haven 4 didn't really show that, but here you see the numbers of patients gets really small, so the statistics gets a bit messed up. If we look at, this is again now the percentage of patients with no treated bleeds. We look at all the patients, we started out with about 70% in the first 6 months, the first 24 weeks, had no treated bleeds, which is pretty fantastic. But the longer you stayed on imicizumab, that kept going up and up. Actually, the last group was a very small group, only 19 patients, was 100%. If we break it into the studies, you see an increasing percentage of patients that are having no bleeding the longer they stay on imicizumab. For the kids, it was pretty flat because the level was so high to start with, it was almost 90%. And even in Haven 3, which is the patients without inhibitors. Then an important thing in hemophilia is target joints. Target joints are joints that bleed over and over and over again. And those are the joints that cause permanent damage. This is showing you what happened to the target joints in the patients. And you can see in each of the trials what percentage of the target joints resolved or went away. And you can see in each of the trials, we're pretty close to 100%. If we take all the trials together, more than 99% of the target joints resolved during the study of emicizumab. So it's very good at getting rid of these nasty joints that keep bleeding over and over again. As far as safety, in the long-term safety, there were no deaths, and there were some clotting events at the beginning of the Haven 1 study. There were actually 5. But as the studies went on and we learned how to prevent these, what this is saying is that there were no thromboembolic events or thrombotic microangiopathy, basically blood clotting events beyond those that were originally reported, which was 5 of them in the original Haven 1 study. So as patients stay on imicizumab, it's not like their risk of getting a blood clot goes up. Only those that have an inhibitor and that are using APCC or FIBA are at risk for getting blood clots. Okay. What about safety? Just a quick look at some safety issues that I wanted to cover a little bit more in detail. So we have, I think I have animation, right? So here's the safety issue. Sorry, the top is the safety issue. And then we have the frequency, how often it happened, how you identify it, mitigation, how do you prevent it, and then just the references that support this. So thrombosis in Haven 1, as I mentioned, 3% of the patients had a thrombosis. How would you recognize that? You'd recognize it, and 2% had something called thrombotic microangiopathy, which is thrombosis of small blood vessels. So 5% in total. The main thing is how to mitigate. Mitigating meaning avoiding. And what we learned in the trials is that if you use FIBA or APCC to treat bleeds, if you use a relatively high dose each day, more than 100 units per kilogram per day, and you go more than 24 hours, that's when these events happened. If you don't use this much FIBA, then you will not, very likely, never get a thrombotic event, because that's the only way we saw those. Another possible safety issue is antibodies against emicizumab, which is basically like inhibitors against emicizumab. The good thing to know here is it's rare. We think it's not even 1 in 1,000. So it seems like it's really, really rare. Much less common than inhibitors to factor. And so overall, there's been 4 reported cases, and we think about 12,000 different people have received emicizumab in the last 5 years or so. So that's like 1 out of 3,000. So less than 1 per 1,000, really quite uncommon. The way to recognize is that if a patient's having bleeding, that's not expected, right? We saw on emicizumab, bleeding almost goes to 0. So if somebody's really still having a lot of bleeding, they should go see their doctor. Their doctor can do a simple blood test called the PTT. And then if that's abnormal, additional testing, which we can do at CHLA, can identify the antibody. Mitigation, there's not really any way to avoid this. We don't know who, we don't have an idea who might be at risk for getting these. What I can say is that all of these, as you can see, were reported in patients with inhibitors to factor VIII. Although I will say we just identified our first patient without a factor VIII inhibitor. So anyway, it's very rare. If you're on emicizumab and you seem like you're bleeding and you're taking your medicine, talk to your doctor and they can help try to figure out if you have this antibody. And then there was this other rare case of an issue with the kidney, which resolved in 1 patient. Okay, so there are other bispecific antibodies that are in development. I'm only going to have time to show you one. And this is the one that's currently starting phase 3 clinical trials. We have one patient who's on a trial. And basically, this is what it looks like. And it's kind of funny because it looks like Italy and the Adriatic Sea and the Balkan countries. So I kind of showed that picture, but this is kind of what it looks like. Basically, why do you need something? Emicizumab is so good. Why do we need something better? Well, I mentioned earlier that there is still some bleeding seen with emicizumab. I also mentioned that emicizumab converts people to mild hemophilia. So what is this graph showing? Sorry, this graph is showing what we call thrombin generation, the peak of thrombin generation on the y-axis. On the x-axis is the amount of the bispecific antibody, how much is in the blood. And what you can see is emicizumab is in blue. So in order to get, let's say, thrombin generation of 50, if I drew a line across at 50, you need 10 to the second, somewhere halfway there, about 500 nanomolars, that's the unit, just say 500 of emicizumab to get to a peak thrombin of 50. If we look at the red, which is mymate, if we go back, you only need about 100 of mymate to get there. So actually, I'm sorry, that's 10. So 10 versus 500, this is a log scale. I get confused with that sometimes as well. Basically, what this is saying is that at 1/50th the amount of mymate, you get the same effect as emicizumab. Another way to look at it is if we take 10 to the second, which is 100, at 100 of emicizumab, your peak thrombin is around 30. At 100 of mymate, your peak thrombin is up here at like 100. So it's basically a more potent, stronger version of emicizumab. Now, it's not available yet. It may never get FDA approved. It's currently in clinical trials, and it could be that by sometime in most likely 2024, if everything goes well, this could become an option for patients with hemophilia A. These are substituting for hemophilia A, so they only work in hemophilia A. So hemophilia B patients, now it's your time to pay attention because now we have drugs that could work in hemophilia B. And I showed you these earlier, so I'm going to skip through this quickly. But we call these rebalancing agents. And the reason is that the clotting system is in a balance. You've got procoagulants, proteins that help make a clot. Notice factor 8 and factor 9 there on the left side. We also have these inhibitors that prevent us from making too much clots, like antithrombin, tissue factor pathway inhibitor, protein C and protein S. So this system is basically always balanced if you have the normal amounts of both. But the system can get out of balance. If you're missing one of the procoagulants, well, then you have a bleeding disorder like hemophilia, missing factor 8 or factor 9, and you have bleeding symptoms. But there's conditions that are like the opposite of hemophilia. If you're missing antithrombin or one of the other ones, you have what we call a thrombotic disorder. You have excessive blood clotting. The idea behind these medications is, can we rebalance the system by taking away, so if somebody has no factor 8 or no factor 9 on the left side of the scale, if we take away antithrombin or tissue factor pathway inhibitor, can we rebalance this scale so there's no bleeding and no clotting? That's the idea behind these. Balance restored, no bleeding, no clotting. But you have to get the balance right, because if the balance is tilted too much this way, you have poor bleed control. You don't have thrombosis, right? You don't have to worry about a blood clot, but your bleeds aren't controlled. If we tilt the balance too much the other way, your bleeding may be well controlled, but you may be at risk for getting blood clots. So with these kind of drugs, it's important that the balance be done very well. So fitusiran is one of these drugs that's in clinical trials. And I won't get into how it works. Suffice to say, it's a small interfering RNA, which is essentially what it does is block the production of antithrombin. So it's directed against antithrombin and reduces the amount of antithrombin in your blood. And it's administered subcutaneously once a month, although it may ultimately be also every other month. So pretty low amount of treatment needed. And essentially, this is what it's doing. This is the bleeding rate in the phase 1 study. And this is the lowering of antithrombin. So in the dark blue, we're lowering antithrombin a little bit, just less than 25%. In the light blue, we're lowering it even more. We're dropping it by 25 to 50%. In the magenta color here, it's 50 to 75%, and in the purple, more than 75%. What you notice, the more you lower the antithrombin, the less bleeding you get. So the concept here was proven in a phase 1 study. I'm going to skip this slide just to get to the phase 3 study, which was just recently presented. So this is the phase 3 study. Patients were randomized to get fitusiran or to continue on-demand treatment. There was a second part that was for prophylaxis. This is the inhibitor study. I'm only going to show you that for the sake of time. There is a non-inhibitor study that was designed pretty much the same and showed basically the same results. But I'm just going to show you quickly the inhibitor study results. The main endpoint was bleeding rate, right? Can we make the bleeding rate go down? And this is the patients. I'm just going to show you that this included patients with hemophilia A and B. Notice 20% of these patients had hemophilia B, because fitusiran is not substituting for like factor 8 or factor 9. It's just dropping antithrombin, so it can work for either hemophilia A or B. So here's the results. So patients who were not on the fitusiran arm, they were getting bypassing agents like 5 or Novo 7 just when they bled, had 17 bleeds per year on average, ABR, 17. On fitusiran, it was 0, not average, the median. The average, the averages here was 1.7 on fitusiran versus 18. So it's a really major reduction in bleeding. What percent of patients had 0 bleeds? Those on bypassing agents was 5%. Those on fitusiran was almost 2/3, 66% had no treated bleeds. And if we look at the all-important joint bleeds, you see again the reduction, 13.4 as a median to 0. And for treated joint bleeds, that was spontaneous bleeds on the left. And this is joint bleeds, 12 to 0. So fitusiran worked really well to control bleeding. The concern with fitusiran is, can you tilt the balance too far and cause thrombosis? And I'm just going to skip ahead a little bit here and show you that there were 2 patients. These 3 are the same patient, just given different names for their blood clot. So 2 patients out of 40, so that's about 2, well, not about, just about 2, you can see 2.4% had a clotting event. So that's a pretty small number overall of patients that had a clotting event. And again, these are inhibitor patients. So other rebalancing agents are inhibiting tissue factor pathway inhibitor. It's another inhibitor, coagulation protein C and protein S, as I mentioned earlier. One of these is administered subcutaneously every day. One is once a week, and some are less often. And I don't want to waste too much more time. This is just the laundry list of these other agents, and I won't get into spending too much time other than to say they seem like they work, but there might be some risk for thrombosis as well. So with that, I'll stop and show you a picture from my last vacation in Croatia. I encourage you to go once you feel safe to travel again. So with that, I'll stop sharing my screen and pass it back to Dr. Ewing.
Well, thank you very much, Dr. Young, for this very brilliant, extremely clear presentation of what's happening in the world of non-factor replacement products. And I'm sure there will be many questions in a little while, but for now, it is my pleasure to pass the microphone to Dr. Amit Soni, who is the director of the hemostasis and thrombosis program at CIBD and a pediatric hematologist, and he will be discussing gene therapy and what is happening at this point in the realm of gene therapy. Dr. Soni? Oh, are we there?
Yep, let me share my screen again. Sorry about that. All right. Can you guys see my screen right now?
Yes, we can.
Okay, thank you. All right, it's a little trickier on the iPad. So I'm going to talk about gene therapy, kind of designer genes. So as alluded to earlier in Dr. Kwan's presentation, in 1985, both factor 8 and factor 9 genes were cloned. If you look halfway down the list for factor 8, you can see that it's 6 times as big as factor 9. So we'll talk about that in a moment. All right. Don't have time to do the whole doodle poll, but which came first, GT or GOT? So gene therapy or Game of Thrones? So which came first, the first subject enrolled in sustained gene therapy for hemophilia B, or HBO ordering the first season of Game of Thrones? in the interest of time, I'll move forward with the answer. And they actually both occurred in March of 2010. So gene therapy, as all of you know, has been going on for over a decade. And as Dr. Young alluded to, with factor, you get your peaks and troughs. With the extended half-lives, it kind of widens out more. Non-factor therapies increase your level to mild levels. And gene therapy hopefully will get you into the mild or even into the normal range would be the goal. So I'm just going to do a little history on how we got to where we are with the gene therapy and why people are using the various different components that they are. So in 2010 at ASH, this data was presented for factor 9 deficiency patients because the gene for factor 9 is much smaller than factor 8. Factor 9 was utilized first for gene therapy. In it, they used the adeno-associated virus factor 8. So we'll talk about 8 versus the others. And the goal was actually to increase production to 5% activity. So really moving someone just to 5% was actually the main goal. They looked at clotting factor levels, they looked at preventing bleeds, and they also discovered that patients also previously had antibodies to this adeno-associated virus factor 8. So adeno-associated virus is a member of the parvovirus. It is small, but easy to manipulate. And in it, there's the wild type, which is what naturally occurs. But you can rearrange the vector genome and really kind of modify the engine under the hood and really insert what you want it to change to occur. Then there are ways to also figure out how to get the vector into the liver. So there's various ways that we'll talk about that with the adeno-associated viruses, but then also once you're in the liver, you want the genetic information to not necessarily be integrated with the host DNA. So you want it to happen elsewhere, which we'll call episomal. And then you also want the genes that are there, the liver cells, to continue to make more factor 8. So how do you guide your gene therapy vector to the organ that you want? So tissue tropism is where different serotypes of the AAV go to different organs. So AAV8 was known to go to the liver, so hence its selection early on. So they packaged the gene into the AAV8 packaging. They have it into the IV bag. It goes through the vein, and then it finds its way to the target organ, which is the liver. What we hope is for the top section where the AAV vectors go into the liver and then normal coagulation factor is produced. However, there are patients where they may already have pre-existing neutralizing antibodies that prevent the AAV vectors from getting to the liver to begin with. One published data showed that neutralizing antibodies are high for AAV2 as well as AAV8. And they noticed that AAV5 actually was low in this particular study. So if you can get past the first step, which is the neutralizing anti-capsid antibodies, you can see the subsequent steps are pretty complicated to get into the cell and to set up shop. What you want is on the bottom right-hand corner, you want number 3, which is the episomal AAV genome, which is where the genetic information is not integrated into the patient's DNA. And once, this is the immune system's response, once you do form the AAV vector goes into the cell, there is a little protein that sticks out, and then you start to develop antibodies to that particular AAV vector. So if you use a particular AAV vector 8, for instance, you might not be able to use that same vector again. Early studies showed that with they did a lot of the studies looking at different doses. And for this example, subject E had a high dose therapeutic level of response, which is followed by the red line. However, in this patient, the patient's liver enzyme, which is highlighted by the blue line, also became elevated. And once the liver became inflamed, the patient's factor IX levels started to decrease. And the example in subject G is where the dose was kind of a mid dose, but even without having a good response, the red line being flat, the patient still had what we call transaminitis or inflammation of the liver, highlighted by the blue line. So what they did in this study and others is they noticed that here the liver enzyme is the green line and the factor IX activity is the orange line. They noted that when the green line was elevated, if they gave prednisone, they might be able to salvage the factor VIII activity level, which is shown in the top left corner of the screen. In section C, they noticed that if they gave just when the little green light blips up right in the middle for subject 6, if they gave the prednisone earlier, which is mild changes, they would be hopefully able to salvage the factor IX level so they continue to be at the level that they're at. So you'll see a lot of studies with prednisone if the liver enzymes are elevated, or some studies are even doing preemptively prednisone as well. So again, the goal for this was the overall factor level of 5%. So we'll talk about liver-specific promoters, which is kind of the AAV vectors. Other things that you look at is the transgene, the actual component, the genetic information that you're given. And then we won't go into detail about the genome configuration of the codon optimization, but that's also another variable that's in play in all the various studies. So now that we know that a lot of people have inhibitors of factor VIII or AAV8, how about if we tried AAV5? So in this study, which is from Unicure, they used the AAV5 vector with factor VIII. And what they found essentially was that with higher doses, cohort 2 had higher doses than cohort 1, they were able to get higher levels of factor IX activity. So now that we know that the AAV component has a role, they use wild type factor IX. What if we use something called factor IX Padua? Padua was discovered in northern Italy from a young adult who presented with a blood clot in his right lower extremity. And what they found is this patient had elevated levels of factor IX. And they found that the factor IX variant of Padua, named after the city in northeast Italy, was actually 8 times higher than the factor VIII activity normally found. So in the subject, he had a factor IX activity of 776, which we know is very high and can likely cause clotting conditions, which did develop in this 23-year-old male. So now, what if you used this factor IX variant, the Padua variant, and use that for gene therapy? And this is what Sparks did. And they utilized their own capsid that they formed, and they utilized this Padua variant for factor IX, and they noticed that their factor IX activity levels were also high as well as consistent. So the Padua variant on the bottom part of the slide shows about a 33% factor IX activity compared to the wild type, which was closer to 5 to 7 as the original studies had shown. So what do we do for factor VIII? So for factor VIII, because of its larger size, they utilized a B domain deleted factor VIII molecule to get it to fit within the gene. So again, another company utilized AAV5 factor VIII. So this is what BioMarin did. And what they found early on was their factor VIII activity levels were high, and initially for some patients very high. And then the levels started to taper off. This was some of the earlier data. Subsequent data actually showed that the level started to fall off even more. And hence, that was, and we'll talk about that in a moment on how that led to the FDA not initially improving it. This is a little bit of an older slide that kind of shows the initial gene therapies for factor VIII. So the top one was the one that we first started with, where if you look at the capsid in the fourth column, it uses the AAV8. Shire and Aspio had the Padua 8 as well. Spark used their own capsid, but used the factor IX Padua. Unicure used an AAV5 with factor VIII initially. Sangamo used an AAV6 with a zinc finger. So the other thing I wanted to highlight was the second to last column, which that most of the patients ended up requiring steroids at some part during their clinical trial. For factor VIII, BioMarin, as we mentioned, used the AAV5 capsid as well as the D domain deleted factor VIII, and Sparks also used their own Spark capsid. And Sangamo, as I mentioned, used the AAV6 as well. Now, some of the things that I know folks had questions about or concerns about, as did providers, was what is the risk of developing hepatocellular carcinoma? So the FDA had placed initially in December of 2020 a hold because there was a diagnosis of one patient with hepatocellular carcinoma in the Unicure Hemophilia B trial. They lifted the hold in April 26 of 2021 after further investigation showed that the AAV vector integration into the subject's tissue sample only accounted for 0.027% of the cells in the liver for that sample. There was no evidence of clonal expansion. They looked at specific whole genome sequencing, and it confirmed that the tumor itself had genetic mutations that were characteristic for hepatic cellular carcinoma and seemed to be independent of the gene therapy vector integration. They then went back and assessed that the patient also had multiple risk factors associated with hepatocellular carcinoma, including a 25-year history of hepatitis C, as well as a history of hepatitis B. Subsequently, then patients were observed, monitored with an abdominal ultrasound every 6 months. Now, what Unicure did for their phase 3 is they still use the AAV5 vector, but this time they're using the Padua variant of factor IX. And then there's been a lot of partnerships that have happened within the last few years. So Unicure and CSL Behring have agreed to a licensing agreement. Most recently, FDA had put a hold on the phase 3 trial for the Pfizer-Sangamo collaboration utilizing the AAV6 vector. And what they found was that these patients, some of these patients had elevated factor VIII levels greater than 150%, which is a potential increased risk for clotting. However, in the study, there was no adverse events noted, but some patients were started on oral blood thinners just as a precautionary measure. Just 2 weeks ago, Novo Nordisk and 2seventy Bio expanded their already existing partnership to look at in vivo gene editing approaches to treat hemophilia A. And so gene editing is different than the other AAV vectors where you're infusing kind of a virus to stimulate the production of factor VIII or factor IX, whereas this is more gene editing that's even looking at altering the genetic component of the actual patient. And then many people may have come across this as well. BioMarin had a press release just recently on January the 9th, which was just prior to the JP Morgan Healthcare Conference. And just as a little backstory, as I alluded to, in 2020, with just 6 months of interim results from their phase 3 trial, they submitted information to the European and to the FDA authorities. Based on those results and how some of the levels were dropping off for some of the patients, the EMA requested 1 year of follow-up data, while the FDA requested 2 years of additional data. So in the press release, they released that information. And what they found was the annualized bleeding rate reduced by 85% from baseline, from 4.8 down to 0.8 on average. They also noted that the factor VIII activity was 23% using the chromogenic assay, which is a two-stage assay, or 36% looking at the one-stage assay, and that was observed at year 2. They stated that they reduced the mean annualized factor VIII infusion rate by 98% from baseline. And they also highlighted that there are no inhibitors to factor VIII malignancy or thromboembolic events. More information of this will continue to be shared at upcoming medical conferences. Currently, BioMarin is meeting with the Europeans with an opinion anticipated in the first half of 2022. And they are also planning to meet with the FDA, targeted for the second quarter of 2022, followed by an expected 6-month review by the FDA. So as Doris alluded to on one of her initial slides, gene therapy is 2020 question mark. It could be by the end of this year or the beginning of next year if the data meets the satisfactory results required by the EMA or the FDA. Now, some of the challenges that are occurring in gene therapy, as we highlighted, is the durability. Is the gene therapy, again, with the BioMarin, sometimes initially the levels overshot more than 150%, and now they've come down to about, as I mentioned, in the 20 to 30 range, 20 to 40 range. How long is it going to be durable for? Is gene therapy going to be one where it lasts for 5 to 10 years, and then you might need to get another vector gene product, or is this going to show sustainable responses? Liver toxicity, as we highlighted, what is the overall risk for hepatocellular carcinoma? So far, there wasn't one based on the original case. AAV neutralizing antibodies, again, a lot of the new clinical trials that are upcoming, and I only highlighted a few. I know there's a lot of great work being done by Bayer, Takeda, and others, as they're having a lead-in study where they're measuring and identifying the AAV neutralizing antibodies first. And if you have the antibodies, then you're not going to move to receive the gene product. So there's an early screening lead-in phase part. But again, once you receive a vector, your immune system is most likely going to create antibodies, so you won't be able to receive that vector again. So it's beneficial that there's multiple different vectors that are being used in clinical trials, because I think all of them will be beneficial moving forward. As a pediatric hematologist, what is the appropriate liver size that we could then perform gene therapy in pediatric patients? Some are speculating it could be around age 12 or so, but right now the clinical trials are for 18 and above. And then with gene therapy, hemophilia still is passed on to the next generation. So the gene therapy benefits the patient living with hemophilia, but not necessarily the offsprings. And one of the other bigger challenges is reimbursement. When gene therapy does finally get approved, how is it going to get reimbursed? And then also, what if a patient is at one center who's not necessarily doing the gene therapy or equipped to do the gene therapy, and they move to another center just to get the gene therapy? There's a lot of coordination that would need to occur between those institutions as far as screening the patient beforehand, the actual infusion of the medication, and then a lot of post-op care as well. So it's a very exciting time There's a lot of research going on into gene therapy, but I just wanted to use this opportunity to give a little bit more of the background on why we're seeing the different products that we're seeing and some of the immune suppression that's being utilized, such as prednisone. And then there's other potential immune modulating medications that might be used in some of the other protocols moving forward. So it's an exciting time. I think Athens 14 is going to be following along the gene therapy patients just to look at a long-term outcomes as well. So usually end with this slide, which TF stands for tissue factor, and then a miracle happens, and then you perform a clot. So many of us hopefully weren't too explicit here in step 2. Thank you very much.
Thank you so much, Dr. Soni. It has been an excellent presentation, and I want to thank all the speakers. These presentations have been so good that we're really way out of time. I hate to admit it, but it's the truth. So I'm going to have to limit the questions that we receive to just 1 per speaker. The first one will go to Dr. Kwon, and her question is, are there any risk downsides to your kidneys or liver using a PEG product compared to a standard half-life product?
The answer is we've used these PEG products for a long time now, and there does not seem to be anything that has been flagged or noted. So the products have shown to be safe there's no accumulation of these products. And PEG is actually in almost a lot of different things, and they have not found any issues with PEG accumulation. Other medicines use PEG, and there haven't been any problems too, or any problems noted.
Excellent, thank you. So the next question will be for Dr. Young. And the question for him is, how do we ensure that the risk of thrombosis is in good balance? Basically, do you have a way of monitoring for thrombotic risk in patients who are receiving fitusiran or emicizumab or any of these approaches?
Yeah, that's a great question. I think the short, brief answer is that you should speak to your physician for any of these drugs to determine, what is your risk-benefit ratio with respect to some of these new drugs, the ones available and as they come out. For example, for a 4-year-old who doesn't have inhibitors, where there's essentially very, very, very low risk for thrombosis in general, who doesn't have an inhibitor, so they're not going to be using APCC, the risk of using emicizumab and a blood clot is, I would say, pretty much 0 or practically 0. On the other hand, if you were 60 years old, if you have, if you're a little overweight or you have some risk factors for heart disease, smoking, sedentary lifestyle, things like that, then you should really speak to your physician about potentially using something that may have the lowest risk of blood clotting. And that may not be, fitusiran or one of these other new drugs that has shown some risk for blood clotting. So I think the risk is really individually based. And that's, I think the prevention is really all about that, figuring out what is the best drug for each individual based on their own risk factors for thrombosis. So I'd say that's the best advice that I can give. For emicizumab specifically, the blood clots have only been seen in patients with inhibitors and only when they also used APCC or FIBA. So if you don't have inhibitors, you can use emicizumab most likely exceptionally safely without worrying about thrombosis. If you have inhibitors, then using one of the factor 7A products to treat bleeds is probably a safe way to go. For the other products, we're still learning. And once the phase 3 trials are completed, we'll have really good ideas about, for whom it is possibly less safe. There may be populations where maybe a little bit less safe of the things I gave you to use some of the rebalancing agents. Thanks.
Excellent, thank you. And for Dr. Soni, he was the last one that gave us the talk, so I don't think there has been much of an opportunity for people to ask questions, but I'll ask.
Perfect, thank you right there. Thank you. Have a good night, everyone. Yeah.
How about if you tell us who is the ideal candidate for gene therapy based on what we know thus far? And I'll let you tell us what you think.
Wow, who is the ideal candidate for gene therapy? Well, I would, right now, I don't think any of the clinical trials have included inhibitor patients. So we don't have data for supporting one way or the other for that. I think some of the clinical trials right now are faced with a conundrum of many patients already being on emicizumab or some other non-factor product. For patients to come off that to get onto gene therapy would be a challenge. I think someone that doesn't have pre-existing liver issues with hepatitis C or hepatitis B, and is in relatively good health, I think would be a candidate. I think someone that also requires a lot of factor medications and the various current options, and there's a lot of exciting options out there now. If those current medications aren't working for that particular person, I think gene therapy would be an opportunity for him.
Excellent. Thank you so much. I want to thank all the speakers. I know that this takes a lot of work to put together this lovely talks. I also want to encourage people whose questions went unanswered or who still need answers to the questions that they didn't get a chance to ask, to contact their physicians or any of these speakers if you have their email contact and ask them directly. So thank you so much, and I'll conclude this meeting that went about 25 minutes longer than we were supposed to, but I totally enjoyed it, and I hope that everybody else did too. So thank you.
Thank you so
Bye.
much. So
Thank
please
you.
don't go anywhere for the rest of the people, because we will have our sponsors presenting quickly, and we will put you in a raffle if you're able to make it.